If you are someone who have been lately diagnosed with heart disease and have been advised stenting, bypass surgery, or valve replacement, there must be a lot of questions coming to your mind. Whether to go for a stenting, whether to go for a bypass surgery, whether to have a tissue valve, whether to have a mechanical valve, whether it is right time to go for the surgery or you can wait. To answer all of these questions, we have with us Dr. Vaibhav Mishra, who is cardiac surgeon, head of cardiac surgery at Max Hospital, Patparganj, New Delhi, today with us. Sir, welcome to the show.
Thank you.
So, sir, you must be getting a lot of patients like these who have been recently diagnosed. Now, they must be thinking whether to go for stenting or bypass. So, what is the better choice for them? And whether they should be going for the surgery immediately or they should be delaying it for some time.
So, whenever somebody undergoes an angiogram, the idea is to pick up any kind of coronary blockages. Our coronary arteries, they develop blockages over a period of time. Sometimes they may happen because of various reasons earlier, like diabetes, smoking, hypercholesterolemia, and things like that. Now, what these coronary blockages essentially do is they reduce the blood supply to the heart, so that whenever you're exercising, you'll feel the pain, which is called as angina. Sometimes these blockages can suddenly deteriorate, causing a heart attack, which could be minor or major. So the idea of angiogram is to pick up these blockages and then offer the best possible treatment. Now, there are three possibilities if somebody has an angiogram. One, the blockages are what we call as non-critical. So what is the non-critical blockage is anything less than 50%. We know that if the blockage is less than 50%, it will not reduce the blood supply to the heart. And in that case, only medical management is required, which is aimed at stopping the progression of blockage. There is no medicine in this world which can resolve the existing blockage or reduce the level of existing blockage. But the idea of medical treatment is to stop the progression of disease, stop that 50% to becoming 70%. Next comes borderline lesions, which are 50 to 70%. And anything beyond 70% is termed as severe blockage, which needs intervention. So now from here we answer your question. If you have got blockage in a single artery or two arteries, you can go for stent. But if you've got blockage in all the three arteries, at multiple places, more than one blockage in same vessel, then bypass surgery offers a better alternative. Fundamentally, stenting and bypass surgery both are separate treatment. They are not the same. The idea is to improve the blood supply to the heart, so that heart gets enough blood supply, you're able to live a normal life without any risk of heart attack. But they both the treatments, they achieve this by a separate thing. Now imagine there's a drain pipe in your house, it gets clogged. You can use a wire to open up the drain pipe. This is something as stenting. Okay, so you are opening up the existing vessel, that is stenting. So again, it makes sense that you can open up one or two arteries only, not the whole length of arteries or not multiple arteries. But when you have blockage in multiple arteries, so you've got multiple drain pipes which are blocked, you will need to change the entire plumbing system of the house. And in that case, you'll need to change the entire blood supply of the heart, which is by bypass grafting, wherein you take arteries from inside the chest or hand or legs and put new grafts. So essentially ensuring that you get a new blood supply system. So though both treatment are aimed at improving the blood supply of heart, they do it by a different way. And as you can understand, if we are opening your own artery by putting a stent, then it would have a less life. So in diabetic patients, stenting is less useful because the stents tend to get blocked earlier. And so in diabetic patients, bypass is much preferable option. So this is how we base a patient for treatment. Less than 50% blockages, we will advise medical management. Anything more than that, based on number of arteries involved, it could be either stents or bypass surgery.
Okay. So, sir, when you talk about bypass surgery, there are different approaches to bypass surgery. Now, what are the options available to patients if they really want to go for bypass surgery?
Okay. So, bypass surgery means that you're bypassing the obstruction. You basically take conduits from inside the chest, hand, legs, bypass the obstruction. That's the mainstay of the treatment. Now, in terms of approaches, one is the standard approach, which is sternotomy. We go in via the chest, cutting the chest bone, which is the sternum. These days, MICS or minimal invasive cardiac surgery is there, wherein we don't go through center, we go from the side, in between the two ribs by means of special retractor. The inside of the procedure remains the same. So, bypassing the blockages, using conduit, all that principle remains the same, but only the approach is different. And obviously, because we are going through a small cut, this technique is not suitable for everybody. There are certain criterias. The heart function has to be good, the lung function has to be good, the target vessels should not be badly diseased. And in terms of age also, it's not very suitable for elderly people or who have pulmonary or lung related issues, because in this surgery, when we go from here, only one lung, which is right lung, is working. We have a special anesthesia called as one lung ventilation, single lung ventilation. So the left lung is not working. So entirely during the procedure, your right lung has to support the entire body. In that case, people with advanced COPD will not be a candidate for that. Somebody with poor heart function will not be a candidate for that, because the margin of error is very less with this small cut. So if something goes wrong, we will not be able to salvage. So carefully chosen, these patients can be done with minimal invasive approach. In terms of conduits, we've got a total arterial bypass. When the target vessels again are of good quality, we can use arteries only from inside the chest without taking anything from the leg. And then we have radial artery also, which is from the hand. So that's a combination. Essentially, all this is dictated by how invasive the disease is, how many vessels we are bypassing, what is the condition of your vessels, are they calcified, how is the heart function. So many things decide this. We have robotic bypass, also robotic, but currently all the robotic surgery is robotic assisted in terms of bypass surgery. Robotic assisted means that robot is used, obviously the surgeon is operating, only to harvest the conduits, but the anastomos, the actual sewing, is done by hands only. The total endoscopic robotic is not that well developed, but maybe in future it can be developed for. Currently it's being done only for one blockage or something, and it's not being so done frequently. But MICS offers a definite advantage in terms of early recovery, less blood loss, less pain, less wound infection and everything. But again, it can be done, not a universally applicable technique, can be done in selected few.
All right. So, if you talk about valve replacement now, which valve you think, people have mechanical valve, tissue valve as an options. So which one you recommend and when?
Yeah, so that's the most common question asked by people who come for valve replacement. Now, number of things dictate this. First remains the age. Mechanical valves are made up of titanium or steel alloy, which basically lasts for your whole lifetime. You have to take a blood thinner, strong blood thinner for that. So usually they are recommended for younger people, 30s, 40s, 50s. 65 is the cut-off age generally, where after the age of 65 we say let's use tissue valve, because tissue valves are made up of bovine or horse's pericardium or pig's heart, and they have a limited lifespan of about 10-15 years. So when implanted in somebody 70, 65, they will still work for 10-15 years. But if implanted in earlier, when the heart is very vigorous and active, these valves will degenerate faster. So 65 years is the guideline. But again, based on social circumstances, things may change. For example, there are many people who come from far off Pacific Islands. When I was in Australia, they would not be able to take the blood thinners, undergo repeated testing and all those things. So in them, the age of 65 was lowered to 60 or 58. But yes, you wouldn't put it in somebody who's 40, 45 years. Essentially, the first criteria remains the age, which decides which valve we put in. Social circumstances can guide us to put tissue valves. Again, one indication for tissue valve in young is a young female. For example, if a young female who is newly married or unmarried and wants to complete the family, then mechanical valve is not a good option, because the blood thinner will cause very difficult pregnancy. It's not impossible to get pregnant, but it will be a difficult pregnancy requiring lots of monitoring, and there is a lot of early pregnancy loss because of medication. So in them we implant tissue valve. which gives them 10 years to complete the family, raise their kids, and then they will need a subsequent valve replacement.
All right. So you spoke about heart bypass surgery, and in that you spoke about few of the tech approaches to surgeries, like MICS or robotic. So when we are talking about this valve replacement, what are the options? So yes, now age determines and other socio-economic factors determine, but if anyone has to go for a technical approach, surgical approach, if he has to opt for, what are the
So
options?
in valve replacement also we can do the minimal invasive surgery, which is done by a small cut. So there was a lady from Pacific Islands, Vanuatu or Solomon. We did a very MVR, mitral valve replacement by a very small cut, um, and she, I saw the pictures on net. She was running and swimming within a month's time. Again, whether we can do MICS or not will depend on what stage you have presented in. Somebody with advanced valve disease, where the heart chambers are enlarged too much, the heart function has gone down, he require multiple valves, 2 3 valves, or redo surgeries or other risk factors, would obviously negate a minimal invasive approach. For any kind of minimal invasive surgery, the heart function, lung function, other things have to be good, and it has to be pretty much, if not early, then not an advanced disease with heart failure or other symptoms, which will make the surgery risky. So MICS option is there, but as I said, MICS is not a universally applicable technique. It is chosen carefully for patients in which it would give the best results. And those patients are younger patients with early disease, somebody with advanced disease. For example, we had a lady recently, she came, she required at least 10 days of optimization in hospital. She came in heart failure. She had mitral valve disease for about 15 years. The heart had enlarged, pulmonary hypertension, a lot of negative things were there. So she couldn't, such a patient will not be operated by MICS. Similarly, there was another lady which had a redo. She came for second time surgery. That also is a very challenging thing to do by MICS. So in general, we can always counsel patients for this, but ultimately, when they come here, based on their echo, X-ray, and so many other things, we can perfectly see which patient will do best with this. If there are other factors which may impede the recovery or make the procedure risky, then it is better to go by a standard approach, which is very safe. And I would like to emphasize that even the standard surgery is very safe these days. The results of any kind of heart surgery, whether it is bypass, valve, or anything, have improved a lot in last 15 years. Any complication rate is 1% or less. The recovery is very quick. It's 5 days. Often we are able to do bloodless surgeries. There's no pain, modern analgesia and pain control methods and everything, with the newer anesthesia, analgesia and surgical techniques. Everything is improved so much that even with the conventional surgery, the results are excellent.
Sir, what are the options for people who do not want blood transfusion during or after the surgery?
So there are, we have operated such patients, Jehovah's Witness, who don't require blood transfusion. Now, there are subset of these patients which accept blood products, not blood, but they can have other kind of blood related products. And then there are some who don't require anything related to blood. There are options, we have a technique called as autologous blood transfusion, where if the hemoglobin is good, then in a blood bag, we take patient's own blood before surgery. That's after anesthesia. We use the jugular vein to drain 2 units of blood. And that blood is given back to the patient after the surgery. That's autologous blood. So that is one thing. The other thing is we have a device called a cell saver. Now, what cell saver does is that whatever blood is being lost in the field, it captures that blood, washes it, and it collects at the end of the procedure. And at the end of the procedure, it is transfused back to the patient. So these two techniques are commonly used, wherein we can restrict the blood loss. There are a few other simple things, like if the patient is on blood thinner, we need to stop it, and things like that, and do a really careful surgery. But yeah, with these two procedures, I think the chance of blood transfusion is really low.
What are the options for patients with heart failure?
Okay, so again, I mean, that's a very good question. Now, heart failure is a very big spectrum. You can be in very early stage where the medications will do everything, or you can be at advanced stage where transplant is the only option. It depends on what stage you are. Now, these days, lot of innovations have been done in both, in medical management also as well as surgical management also. So we have newer drugs which improve the heart function. We have, you know, um, drugs which improve the heart function at an early stage. So when commenced, you will not, the heart function will stop from worsening, but they have to be commenced at an early stage. So newer drugs have come in. Beyond medical management, if we talk, then there are things like left ventricular assist device, which is like an artificial heart. The device is costly, it is implanted inside, and by a battery charger it is connected. So the patient can go on to live his normal life. For these devices will give you 5, 6, 7 years, but ultimately they are a bridge to transplant, that sooner or later you will require a transplant. Okay, but in case you're not getting a heart, and it's not easy to find a heart, so you will still have an LVAD, left ventricular assist device, which will save you till you get a heart. Heart transplant, obviously, for a young patient. Now there are many, not everybody is a candidate for heart transplant. We have to do a huge subset of investigations to find out if you're right candidate. But generally, if I tell you, anybody over the age of 60 is not a candidate because of various reasons, the healing power of the body and so many things. So younger patients are more candidate for transplants. They will do well because again, the heart also has its own life, the transplanted heart. And with all the medications which are given as a part of immune suppression, elderly patients will not be able to tolerate it. So many other reasons. So younger patients do well with transplants. For older patients, medical management remains the thing. LVAD comes in between. There are few other things. If nothing can be done, then there is cardiac resynchronization therapy, which comes in form of placement of certain electrodes or leads in the heart. It is called a CRTD, where we can pace both the chambers of the heart to increase the heart rate and get some benefit. So that is one more procedure which is done in cath lab. Then sometimes if we are not able to do anything, then there's procedure called as AICD, which is implantable defibrillator, because when the heart enlarges too much, it goes into abnormal rhythm, which can cause you to have a cardiac arrest. This AICD, what it does, it senses your heartbeat, and if you're getting that rhythm, it will give you a shock and sort of save you from that. So, but this does not remain a part of treatment. It is something to prolong your life and something of palliation, but that's also a therapy available. And sometimes, these patients may require only AICD. What one may require would essentially be based on the investigations. What is the cause for heart failure? Now, sometimes we've had patients, it is important to find the cause of heart failure also. Sometimes we've had patients who had coronary artery disease. They came with a very poor heart function. We did a viability study, and we found that there was a lot of heart which was recoverable. We did a bypass surgery and the heart recovered. So now sometimes heart failure may happen because of valvular disease. In early stages or even in advanced stages, replacement of valve may help. But if you're beyond a stage, then it will not help. Now, and then there's certain subset of disease called as cardiomyopathy, where the heart muscle weakens by itself or by various unknown factors. That's why it's called as idiopathic. There are thousands of factors which can be identified. These are predominantly the cases which cannot be dealt with normal surgeries like bypass or valve replacement. And these are the patients which will require some form of intervention in form of, LVAD or heart transplant or other things. So first thing is to find out the cause for heart failure. If it is a correctable cause, do the corrective surgery like bypass or valve replacement. If not, then identify the other causes. If something is correctable, correct it. If not, then go for these things. Ultimate treatment beyond a certain stage, obviously you'll get a medical management for a lot of time. We want to prolong your own heart because there's no substitute to your own heart. Even if we can prolong it by medical management for 2 years, 3 years, it's still getting then a transplant. So the first step would remain to give you medical management, to optimize your condition, to make your heart work as long as possible. And in the later stages, LVAD or transplant remain the option.
So, sir, if you talk about transplant, how easy or difficult it is for international patients, especially?
See, in India, the transplant laws basically are not very favorable to international patients, because obviously, if the heart is made available, there are people on the list. But I'll describe it for a domestic patient. Okay, so for a domestic patient, if somebody has been diagnosed with heart failure or requiring a transplant, he goes on the transplant list. And based on his blood group and other matches, whenever the heart is available, he would be called for transplant. But this also entails that you live close to the hospital. So busy transplant programs, they ask the patient to live close by, close to the hospital for 3 to 6 months. They assume that in that much time you may get a heart, and after that also you have to remain close to the hospital so that you can come back for follow-ups, drug treatment, and all that. Overall, it is very variable, of and unpredictable when you'll get your heart, because so many other things have to be matched. Apart from blood group and NHLA and all those things, your weight, height, so many other things have to be matched. So it's not easy to get a heart, because here we are talking of human heart of somebody who's basically brain dead and has got a working heart. So such situations, and then the family has to agree for donation. So there's still a lot of taboo around donation in India, and even outside India, the availability of such hearts is very limited. So it is not something which is in huge numbers, but yes, patient, they are recruited on the list, and every now and then when the heart is there, they are called on the list.
So, cardiac surgery has evolved quite a lot. Uh, what are the latest advancements in cardiac surgery that you see?
Okay, so the advancements have been in everything, not just surgery. Right from diagnostic methods. Let's talk about diagnostic methods. Our echo machines are much better now. We have got 3D echo machines in hospital. We have got in OT, we have got advanced transesophageal 3D machines which help us perform the operation better. So diagnostic techniques have improved a lot. All the scans, images, everything, diagnostic things have improved. Then if we talk about anesthesia, anesthesia has become better, pain relief has become better. All these things contribute to early patient recovery. Our surgical methods have become better, over the period of time. Everything, right from instrument to sutures to everything has gradually evolved so as to make the surgery more and more safe. Okay. Then, we have gone to do these surgeries by smaller cuts. We have gone and done these surgeries without blood loss. Every surgery which I do is beating heart surgery. In old techniques, the heart used to be stopped for bypass surgery, but we do a beating heart surgery where the heart is beating, and on that the grafts are put. So that's an advancement. Then MICS, even the MICS I do is a beating heart MICS, whereas this is just opposite to MICS which happens in Europe, where the heart is arrested, because they still do the arrested heart surgery. And we're gradually moving on to robotics and everything. Evolvement, it's a continuous process. Surgery has become safer. Uh, Pre-op, post-op, intra-op period has become much safer. Monitorings have become safer. So overall, every small things have contributed to this. And essentially, what it is doing is all these steps have not just made the surgery easy. What they have done is majorly we are able to operate much sicker patients now as compared to 10-15 years back. Patients who were denied surgeries 10 years back because of the advanced disease, or 15 years back because of the advanced disease, are now being operated. We get many such patients from from islands, from Fiji, and who are at a very advanced stage of the disease. They are borderline operability. But we have been able to successfully operate nearly all of them. That is again advancement. We don't have to say robotics is the advancement only. The advancement lies in form of small things which have enabled us to do surgeries which were previously not possible, and everything has contributed to it. So I think the major thing which has developed is right now we are able to perform safe surgery in almost everyone. You know, People who were inoperable previously, even they are being operated. So there's a very small subset of patient which we see no for surgery even in advanced stage, and they recover well. And they recover well not just because of surgery, but because of the good post-operative care and monitoring systems, medications, everything.
So, sir, what would be your message to patients who need bypass surgery or open heart surgery, but they're scared or they are delaying it? What would you suggest?
Yeah. So, look, cardiac surgery is a very gratifying surgery. It gives you life which no other surgery can. And it not just prolongs your life, but it gives you full functional recovery. You are able to do things which you were not doing before. The chances of anything bad happening or a complication is extremely low. So if you have been advised heart surgery, you should go for it, because that will add not just years to your life, but productive years to your life. You are after bypass surgery, you're looking at 20, 30 or more years, and productive years. You just have to keep your diabetes and other things under control, and the grafts these days don't get blocked. We have valves which will last for your whole life. So there's no need to be scared of cardiac surgery. We have reached that stage that surgeries are extremely safe, complications are extremely rare and unforeseen. But overall, if you've been advised surgery, you should go for it at an early stage rather than at a later stage, wherein things will be even more complicated. So there's no need to be scared of heart surgery.
And so, can these blockages also be dealt with naturally, like natural herbal remedies, Ayurvedic medicines, or
Unfortunately,
food, diet, anything?
yeah. So unfortunately, no. Once developed, these blockages will not go away with only these methods. While these methods are very important, any lifestyle changes are very important, your diet, exercise are very important, they will not reduce the existing blockages. They may stop the progression, halt the progression, and also these methods have to be done before you develop blockages. So any kind of preventive measure which people talk about, whether it's diet or exercise, has to be implemented very early in life, at the age of 30s, 40s, so as you get a benefit in the age of 50s or 60s. Once you have developed critical blockages, these kind of therapies will only waste your time. But yes, you have to do them, because if you've got a stent, you don't want the stent to get blocked. If you've got a new graft, you don't want the graft to get blocked. If you're diabetic, you want your sugar to remain under control in less medication. So you still have to do exercise, diet, whatever you feel like, lifestyle changes, but they will not reduce the existing thing. And about the herbal things and all, anything, it's more of a misinformation or misconception. There's nothing which will dissolve the existing blockage.
Thank you, sir. Thank you so much for answering our questions. I'm sure these will help patients decide what to do best for them. Sure. Thank you.
I would like to tell everybody about 5 important symptoms of heart which one should never ignore, so that everything is diagnosed on a timely fashion. The first symptom is chest pain. So any kind of chest pain, don't attribute it to acidity, gas or anything else. If you have chest pain anytime, any abnormal sensation in the chest, even heaviness, seek medical attention. Next is breathlessness. Anytime you're short of breath, more than usual proportions, you should seek medical attention, because it's an important sign of cardiac disease. Third is palpitation or racing heartbeat. If you ever get racing heartbeat while sitting, then it is abnormal. Syncopal episodes or fainting out, this is a sign of neurological thing, but can happen in a lot of cardiac diseases. And fourth is, fatigue, unexplained fatigue. There are a few other signs like swelling in the feet, tiredness, veins in the neck. If you or anybody in your family has any of this, then you should not ignore. Seek help from your doctor who specializes in cardiac thing. And obviously, once diagnosed anything, do not delay the treatment. Remember, timely treatment can add so many years to your life.
Thank you.
Thank you so much.
Thank you.